Welcome all. Okay, sure. Welcome all to the Enigma called Glaucoma. So, who is a glaucoma suspect? Glaucoma suspect is an individual who demonstrates one or more factors that put them at a higher risk of developing glaucoma, but they do not yet have glaucomatous damage. So, for the diagnosis and management of glaucoma, we can basically break it down into three primary components. One is the intraocular pressure. The second is the structure, that's the retinal ganglion cell and their axons making up the optic nerve. Third is the function, which is primarily the visual field, and in later stages, the central vision. So it's very important to have a good correlation between the structure and the functional deficits in glaucoma, and that will be the recurring theme of my presentation today. So coming to the first one, is high intraocular pressure always ocular hypertension? So what are the signs of ocular hypertension? So intraocular pressure more than 21 millimeters of mercury, and of course the structure and the function is still pretty normal. That's optic nerve and visual fields are normal. So the case one is a case of an invisible thief. A 31-year-old male came to me with bilateral ocular discomfort, and vision is normal. The pressures are high, 33 and 26 millimeters of mercury. The central corneal thickness is on the lower side. Gonioscopy is open angles both eyes. And this is how his fundus and optic disc look like. They're pretty normal. And there's the red-free image is normal. And so his visual fields, they are normal actually, and some changes on RNFL analysis both eyes. The pressure is
One
very
minute.
high.
We'll discuss this later. You'll case one, case two wise.
Yeah,
Or can
actually,
it be better that way, right? I want to ask something, so that's why I'm like interpreting.
yeah, please go ahead. What do you want to ask?
So the right side disc, there is a wedge defect.
This one?
Yeah.
Yeah, looks
Yeah,
like somewhere. Yeah,
yeah.
yeah, this one
Actually, I looked
looks
into
like.
it in greater detail, but this is actually, you see, this is if you see the color of this one and you see the color here, they match
Right.
actually. So
Ah,
this is
It
not
so
matches.
that is what why I'm asking is this is what confuses us in OPDs.
correct,
Yes,
correct.
absolutely.
So that is
True.
why I
Yeah.
actually good that you looked at it. See, this is because the brightness, if you see the brightness here and the brightness here, so this is sort of this is what the LV people taught us. Look at everything around also. Look if the color matches or is it a darker color than the surrounding fundus. See the
Okay.
color here are almost matching. It's not darker. When you come when
Even in that this one there are some striations if you look carefully. It's just illumination effect.
yes, yes,
So
correct.
in the
So
left eye, there are the striations, but not I
Hmm.
was not able to appreciate in the right. In the
Yeah,
left,
right.
there are
There are.
striations.
Yeah, there are.
Okay. Okay.
The right
Yeah.
also.
Yeah. Okay. Thank you. Thank you.
So here in the see my go-to actually my go-to thing is the visual field actually. My go-to diagnostic test in glaucoma is the visual field, and see the visual field are absolutely brilliantly normal in the right eye. There are some changes in both eyes because see I don't rely much on OCT because same patient if you repeat after dilatation or on a second visit if the patient is not squeezing very much the visual these OCT these things can change. They do change actually. So I don't rely much on the OCT. My go-to diagnostic test for glaucoma patient is visual field examination, and this has to be repeated a couple of times because usually in the first or second instance you're not going to get a good fields from a patient. So this is how the fields look like. The pressures were high. Put him on Mysopt and put him on three drugs. Basically, pressures came down to 16 millimeter mercury. So the patient was very good in compliance and very good with follow-up. Also, he used to come every 15 days. But then the trouble happened after sudden 3 months. There's suddenly increase of pressures, and it went up to 38 and 36. Now on slit lamp examination, I finally found these granulomatous creatic precipitate and grade 1 cells in flare. So the gonioscopies were again open angles and further probing revealed a history of antecedent fever actually. So I made a working diagnosis of viral granulomatous anterior uveitis and put the patient on fluoromethalone, indomethacin and valsivir actually. And the pressures fatafat se came down to about 12 and 13 millimeters mercury in both eyes over the next 5 days and they stayed there. So over the next 3 weeks, I stopped all anti-glaucoma medication in both eyes, and the patient is now actually free of the diagnosis of ocular hypertension and the risk of glaucoma in the future. So the moral, like the reason for the high intraocular pressure during the first visit might have been anterior uveitis itself, which I missed, and the sudden rise of intraocular pressure, despite good compliance with medication, started me into looking for another cause of IOP spike. And on good slit lamp examination, I found it to be anterior uveitis. So the moral of the story is there is no substitute for a good clinical examination. Consider revision of diagnosis at every step. Don't love your diagnosis. So then, before this next case, beware of the single episode. It may not tell the whole tale. Like a snippet from a grand story, it's just a tiny detail. So, so this is case number two. One eye every time,
Sir,
27-year
wait,
old.
wait. Can we have some discussion? I think some Rashi has some questions.
Yes, yes.
Yeah, so just on the basis of granulomatous keratic precipitates, how come we can come to a diagnosis of
Yeah,
viral?
actually, yeah, viral. See, it was bilateral. The pressures were high, so it is mostly in viral. See, I ruled out other thing. I did a Montu also. I didn't include in this slide. These slides are I prepared for the general ophthalmologist of my city. I'm not going into the details of the diagnosis. I did all the relevant tests for anterior uveitis also for this patient, and all of them are negative. Montu was normal. Actually, B27 was negative. I did the rest of the things actually.
Actually, B27, anyways, we are not looking at because it is granulomatous.
Granulomatous.
So non-granulomatous one is ruled out. Other
Yeah.
thing is just because it is, a granulomatous, there are even sarcoidosis comes into the picture.
Correct. I looked at the gonioscopy. The
Usually
gonioscopy.
unilateral. Yeah, but not every sarcoid patient will have a tent-shaped past or a Berlin nodule, right?
Yes, see,
So
agreed. Dr. Rashi, the point is in sarcoidosis, like as whatever little experience I have, I've rarely found pressures as high into the late 30s or 40 millimeter mercury with sarcoidosis, bilateral. I have very limited experience of actually diagnosing sarcoidosis. But what I have seen, yes, I have seen a lot of cases now. At least I have 12 documented cases with myself of viral anterior uveitis, and they usually have very high intraocular pressure, where it is hypertensive viral anterior uveitis. So that is what actually started me into thinking that this is viral to begin with. And he was actually
okay.
complaining of some back pain. He was actually not exactly a laborer, but he was into a factory worker. So I just on the just for the heck of it, I got his HLA-B27 done, and yeah, rest of the tests were normal actually. But in the
Okay,
mean,
like
I did put him on Valsivir in the meanwhile, just because I saw this high pressures and he at his granulomatous type. So I did start him on Valsivir, and within 5 days, his inflammation came down, and only on oral indomethacin and topical fluorometholone. They were not very strong steroids, and his
mhm.
inflammation came down, pressures came down. So, that's how.
How I look at it is maybe the pressures were high because of the inflammation, or it was just this episode which, anyways, came down because of the anti-glaucoma medication, 2 drops that you had given, and
No,
concurrent.
Dr. Asha, I actually beg to differ there. He was very compliant with the medication. He was already on the medication of past 3 months. And then
Okay,
he had this, yeah, and then he had this spike of intraocular pressure. I would have
okay.
continued, actually the moral of this actually case is I would have continued him on anti-glaucoma medications, for a very long time, maybe for a lifetime. But the second spike of intraocular pressure, this is what got me started, on this slit lamp examination, finding out this granulomatous anterior uveitis, and revising my diagnosis that this is not ocular hypertension. So this is the moral of the case. Yes.
Dr.
No, but
Sag,
what do you think? The first episode was a viral uveitis.
Yes, must have been actually, which I missed. This is what I had come to in the second slide, that it might have been yeah, anterior segment inflammation, the first episode itself, which I might have missed actually.
Dr. Sagar, what was the distribution of the KPs? Was it in the Waltz line or it was diffused throughout the cornea?
It was like they were diffuse, but they were sort of not throughout the cornea. They were more centrally and some inferiorly also. And they were non-pigmented. They were not like sometimes you get in zoster those pigmented big KPs with very high intraocular pressures and iris like changes and people not reacting. That was not that type actually.
Okay. So basically, it's a response to the antiviral which made you to diagnose that as a
Correct.
virus.
Correct, sir. Within 5 days, with
Preserved,
oral
yeah.
indomethacin, just oral indomethacin, antivirals, and only topical fluorometholone. I didn't change the dose of the anti-glaucoma medication. He was on the same dose which he was on the last 3 months, and I didn't stop his Travatan also. The PG analog I didn't stop in this case. I don't know for whatever reason, but within 5 days his pressure just plummeted. Come up again, back again. So I thought this is maybe have been anti-uveitis which I missed in the last episode also. So, in fact, I changed my diagnosis from ocular hypertension to viral anterior uveitis induced ocular hypertension. Sorry, high
You could
inflammation.
have done a simple Shermer's test, to
Shermer's
kind
for
of
what?
no, if to rule out sarcoidosis, so that's what you initially thought, isn't it?
Correct, sir. Like, of course, I was thinking more in case of tubercular and sarcoidosis. I did a gonioscopy as a routine thing for all my glaucoma patients, so nothing was there. So I ruled out twice.
Bilateral granulomatous uveitis. Was he under any brimonidine or anything?
No, sir. I put him on dorzolamide, timolol, and Travatan actually, PG and low.
How long did you continue the antiviral?
Sir, antiviral I continued for 15 days. Initially, I put him on 3 times a day, 1 gram 3 times a day for the first week, and then I made it twice a day, and then stopped, sir.
Okay, fine.
So yeah, I'll just jump on to the second case. So
Sir, one more question, please.
yes,
So, sir, do you find viral anterior uveitis after adenoviral conjunctivitis? I have found two patients with the
yes,
same.
yes, yes. In fact, I actually noticed this year only that it basically endothelitis. In fact, you suggested that you were seeing cases. I
Yes,
didn't see
sir.
it till that point of time. I had seen none, in fact, and then somehow it happened after a week. I saw two cases in one day. Endothelitis with AC2 plus cells in flare, and they respond
Right, sir.
beautifully to valacyclovir. So yes, I had seen that conjunctivitis, severe conjunctivitis, and changing over 2-3 days into anterior uveitis.
Right, sir.
Yes, this
So the
and
plan of management.
sorry, please go ahead.
So the preferred drug, sir, the topical steroid remains fluorometholone, sir, or do you have to switch to pred sometime?
See, if mother, what I have seen is like valacyclovir is like I don't know. I felt it is a magical drug, and
Right.
yeah, with you give it, and then even if you give it twice a day, 1 gram, and the inflammation, if it is because of viral or the infection, even in keratitis, if it is a bit viral, it just goes away. It's just magical drug. You don't have to
Right,
switch
sir.
to the strongest steroid. Just keep using fluorometholone. Start the valacyclovir. Just see in 2 days' time, the inflammation will all be gone.
What is the dose of that?
1 gram, sir. 1 gram Valsivir. I use from Cipla Valsivir and 1 gram BID or TI, mother twice a day or thrice a day.
Right, sir.
Okay.
Would you say this is some kind of variant of Fuchs uveitis syndrome?
नहीं सर,
Although it was bilateral.
फ्यूक्स वाला नहीं पैटर्न था सर. एक तो विट्रस was clear absolutely, and this was very acute, and there were no changes in the iris, and the KPs weren't looking like Fuchs. They're like Fuchs, they are all over the cornea actually, and
They're
so
not, are they granulomatous in Fuchs?
so it's probably somewhere between non-granulomatous and
They're
granulomatous.
always fine, kind of dusting, kind of
Fine
a thing like
stellate.
that. Fine stellate type, yeah.
So this is I'll just in to save some time, I'll jump onto this case. 27-year-old male came to me with ocular discomfort, redness, blurred vision 2 days. So the important thing was he was using my soft. He was using 3 drugs in one eye, and that's the right eye, and 1 drug in the left eye. That's the important thing for the last 2 years. And old notes revealed he had multiple episodes of high intraocular pressure in the right eye and normal visual fields and OCT, but he was continued on anti-glaucoma medication. So young guy, he was using anti-glaucoma medication for 2 years. So this is what I saw him with actually in slit lamp grade 1. It's not, the image is not very clear, but grade 1 to 2 cells in flare and some cells in the anterior vitreous space also. And the pressures were really high, 36 millimeter of mercury in the right eye. Left eye was absolutely normal. Gonioscopy, open angles, central cornea thickness normal. So this is how his fundus look like, normal, red-free normal, and visual fields normal. And you see there's some changes in the RNFL analysis in the right eye superiorly, but that can be expected due to previous episodes of high intraocular pressure, which might not have been well contained, and similar changes on GCL, IPL analysis. So I asked the patient to stop PG log right away, put him on fluoromethalone, added indomethacin and Dimox, and 12 millimeter mercury over the next 2-3 weeks, and the visual field and OCT were normal. So gradually, I took away all his anti-glaucoma medications. The patient was compliant. He followed up with me closely. Pressures remained normal. So I discussed with the patient that, see, it is not, you haven't got glaucoma. It is a one time of inflammation that you are getting, and it can happen in the future. So actually, the diagnosis of Poisson-Schwarzman syndrome here, and so he had been following up with me. He had one more recurrence in the right eye, but he is practically off all anti-glaucoma medication. So this is the case number 2.
Dr. Sagar,
Yes, ma'am.
what are your indications of giving indomethacin? Because I see it's very an intolerant drug for the patient. And what dosage?
He was a young guy. So dosage, sorry, I cannot remember it from the top of my head, but it is Indocap SR. I just gave it twice a day for 3 days only. And I gave it with under cover of SA lock. So just forgot the dosage actually.
To give Indocap.
Yeah, Indocap SR.
What cases do you give it in?
Sorry?
Which cases do you give Indocap?
Very, very few cases actually. This young fellow, I really don't want to give him steroids. So I just wanted to see the effect of indomethacin, and I don't know, just the Dimox or the effect of indomethacin took away the inflammation, or the fluoromethalone. Actually, it's not per se. It's not something that I'll like pass on the message that it has to be used. It was just a one-time use in this boy, and it worked. And so that's it. Mother, like now I use it very rarely. I'm switched more to Etocoxib actually.
Okay.
Do you find fluoromethalone working for intraocular inflammation?
Yes, sir. Actually, sir, see, it is not one drug at a time, so it is sort of a cocktail therapy, NSAID plus Dimox plus fluorizone. So I don't know what exactly worked to bring down the pressure, but his inflammation subsided, pressures came down and remained low because it was due to inflammation, sort of an immune reaction to some viruses probably. So the moral of the story in this case is like, we don't need to, like, if we see a high intraocular pressure, we don't need to keep continuing the patient on anti-glaucoma medication.
Very true.
Just, we review the thing, like, is it a one-time thing, one-time episode, or is it a continuous thing? Because these young people are, you putting them on anti-glaucoma medication and telling them to continue for life. That's it. So so the next case, this is a case of, this is a very interesting case, and this is a case of a hot eye. And this is a 31-year-old male. He's a kebab seller by occupation, and he came to me with a really red-looking eye, swollen lids, and severe conjunctival congestion and hyperemia. And he had been diagnosed elsewhere with anterior uveitis. He was on maximum possible, the word important here is maximum possible, not maximum tolerable anti-glaucoma medication. And he was on oral and topical steroids as well. So the steroids were there to control his anterior uveitis. And since he was he had a steroid response, so he was on maximum possible anti-glaucoma medication. He had history of even, and he was allergic to Dimox sulfa, so he was not put on Dimox. And when I saw him, and most people had referred him to a higher center, and I did the same on the first instance actually. So his vision was counting fingers only, and corneal edema, pressures were right up there, 50 millimeters of mercury. Gonioscopy was very faintly visible angles, but they seemed to be open. So yeah, this is the fundus image from my Bareilly Topcon fundus camera, and this after his pressures have come down. The cornea sort of cleared out, so I was able to see his pressures. So I was able to with an MRF visual field analyzer, and right eye seems okay. The left eye there's some change. The superior field and the central field also seem to be depressed. And so I repeated the macular program. Seems some sort of a depression here, but maybe because of the inflammation, of the chronic inflammation he had for close to 3 to 4 months. And this is just a poster about the MRI visual field analyzer. It's just it cost me 1.25 lakh rupees. I'm using it in Bareilly. And so the important thing is I took him away of most drugs actually. Just one anti-glaucoma medication, that was Mysopt, and Nevanec for his inflammation and frequently lubricating eye drop, and naproxen for his inflammation, and fexofenadine for his allergy, which might have been because of the Brahmanidine, very severe red eye, and stopped all steroids. And his anterior segment, there was no cells and flare, but somehow everyone just decided not to stop the steroids. And the important thing is his BP was right up there, 190, 112 millimeters of mercury. So I did a lot of counseling. I almost spent 30 minutes counseling him about antihypertensive and anxiolytics. And eventually his pressures came down to 60 millimeter mercury on just Mysopt, whether that's dorzolamide and temolol. And his lid edema and conjunctival hyperemia also subsided. And then I referred him to a rheumatologist because he has this inflammatory back pain. So likely he has a HLA-B27 related anterior uveitis. And so that's it about this case. And so a word on BP and intraocular pressures, and meta-analysis, and they did find a positive association between systolic BP, diastolic BP, and intraocular pressure. So it's very important to look at the systemic features also, like don't forget to take the blood pressure and other things. So the moral story here is not to overload the patient with anti-glaucoma medication. They can cause allergy and uveitis, and a severe blepharospasm can lead to erroneous intraocular pressure measurements. In a steroid-sensitive patient, it's best to switch to immunosuppressives and strong oral NSAIDs and look at the systemic factors like metabolic control. Moral stories: do not inflame an already inflamed eye.
So what was the diagnosis in this case? What did you diagnose?
Basically, the patient had anterior uveitis, and there are some pigment on the lens in the right eye also. So he is likely a case of inflammatory back pain and HLA-B27 associated anterior uveitis. And for that, he was put on steroids, and since the steroid caused a high intraocular pressure, so everyone just start. And so he was on 4 anti-glaucoma drugs when he came to me, and nobody actually stopped steroids. Everyone was just happily adding on anti-glaucoma medication, still continuing the steroids. And somebody even gave him a PST also sometime back.
Oh,
Yeah, so the thing is, like, it is very important, if you are having like the moral of the story is like to continue. Very important to measure the intraocular pressure at every visit of your uveitic patient if you're putting them on a steroid. And like early switching over to NSAIDs or immunosuppressive if your pressures are really jumping up. So it's a tricky situation, but the thing is, like, uh, I cannot actually, I don't have the pictures, but his eye looked so bad, and it was looking terrible, swelling. All half of his face was swollen, and very red looking eye lids, very swollen. So he was actually, because the excessive medication, it was causing a lot of allergies also, the preservatives. So just the moral of the story is, like, keep it simple. Try to keep it simple.
Uh, I would just like to ask, has anyone experienced that HLA-B27 patients coming up with high IOP? Like,
Yes, ma'am.
in
Yeah, that's interesting. Most of them do have low IOP, but I have two patients who came to me initially, initially when I measured the pressures were equal in both the eyes, put them on steroid, and the pressure really rose up. So the most likely they are steroid sensitive initially. Yes, and I have seen patient of HLA-B27 virgin eyes, not on any medication, pressures quite high also, like high as in 28 millimeters of mercury. 1 month I saw one patient. So it has variations, and I have seen HLA-B27 patients with granulomatous creatic precipitates, with hypopion. Of course, everyone has seen them with hypopion, swollen eyes, and everything.
Is it a
Uh,
possibility that there is this, multiple factors? Like I've seen many reports showing sarcoid positive and HLA-B27 positive.
Yeah, that can be a possibility, but here we cannot ignore that he had inflammatory back pain. He had residue of anterior uveitis in the right eye. Also, there was pigment on the lens, and
No,
like
not in this case. I am talking about the high IOP with HLA-B27. Is it
yeah,
possible that there could be a other multifactorial cause of
yes,
that
yes,
condition
yes, of
causing
course.
IOP rather than only HLA-B27?
Yes, of course. See, ma'am, if
Steroid
you
responders.
yes. So you think of other possibilities, you have to, check one box at a time. Patient walks in, you see it as typical HLA-B27 inflammatory back pain present. You think of that patient, that scenario first. Even if the intraocular pressure is high, you try to control it with oral NSAIDs. Now my go-to drug is etorocoxib, and put him on steroids. And sometimes just with the steroids, even if the pressure is high, the inflammation goes down, the pressure also goes down. So yeah, if it is not controlled, then you think of other things. But this is like one thing at a time.
if there are a formation of a synecdoche, like you said, a virgin eye presenting with a high IOP in a HLA-B27 positive one, if
Yes,
like synecdoche had formed and everything, an angle and all, then it is okay. I mean, I might still have to think once again if the IOP is high, because HLA-B27 ones typically, because of the ciliary, the thing that gets involved first is the ciliary this thing, and they usually come with a hypotonous eye, or there is a drop in a intraocular pressure. High
yeah,
IOP in a HLA-B27, I will think again. And another thing, steroid responsiveness in a HLA-B27 positive patient, again very very less likely, because these are the patient whom we put on really hourly steroids, or sometimes every 45 minutes for the initial first 2 3 days or the so. I have never ever encountered any patient uh, with a high IOP in a HLA-B27 positive. And
ma'am.
as regards the other things like sarcoid and HLA-B27 or whatever, the test coming positive, we will not label the patient to be, even if the HLA-B27 is positive. If the clinical phenotype is not suggesting, then we will still not label, because few among the normal population will also have the test to be positive.
Correct,
So,
correct, correct.
and whatever the ma'am was saying, that sarcoid might be causing that or what, whatever is coming positive, we will not label them at, if suppose you are thinking as sarcoid and HLA-B27 together, again it is not fitting. And granulomatous KPs in HLA-B27, then it is a non-granulomatous by definition. So if
Correct.
you are seeing granulomatous KPs, then definitely it is not HLA-B27 positive, even if the test has come positive.
Positive, yeah.
Yeah.
So what could be the diagnosis? The revised diagnosis if there is increased pressure, corneal edema, uveitis under the
Most
maximal
likely
medical
this
therapy?
most likely he was a steroid sensitive patient, and Malal, I definitely put it. He's got this inflammatory back pain. I've referred him to a rheumatologist because we just have got a visiting rheumatologist in our city. So, like in a week's time, we'll be seeing the rheumatologist. I'll get to know what diagnosis the rheumatologist put forth. But I have got patients, in my opinion, like HLA-B27. I have done a bit of literature search also. I had included studies earlier in this talk, but I deleted it in my earlier talk. But I've deleted them. Actually, like any anterior uveitis, it causes hypertony because the ciliary body gets involved, then there's less formation of aqueous humor. But the inflammatory material can itself clog up the trabecular meshwork. It can inflame up the trabecular meshwork, and so that could in over a period of time, it can itself, the inflammatory material can itself cause a rise in the intraocular pressure. It is not like the ciliary body hypotony is so much, because see, at times I see HLA-B27, typical case of HLA-B27, the pressures are how much, like 16 in one eye and 14 in the other eye. It's not like 16 and 6. Usually like 18 and 16, 18 and 12, or 18 and 18 millimeters of mercury in both eyes. It's not like so severe a hypotony that it cannot be, taken over by the inflammation of the trabecular meshwork or the inflammatory material just going up and clogging the entire thing.
Hmm.
Did the patient give any history of similar episode in the right eye? Although you found one pigment on
No,
the
he didn't give any history, but I did see pigment on the anterior
yeah.
capsule.
Hmm.
So that to me is like a sign of resolved anterior uveitis in the right eye. Maybe I don't know what was the severity of that episode. Was it severe enough to cause any discomfort to the patient, or it just resolved with subclinical sort of an episode in the right eye? But left eye, it was definitely, it must have started off with an anterior uveitis. He was put on a steroid. He was a steroid responder. Pressures went up. So, like the thing about this case is like everyone kept topping up with him with the anti-glaucoma medication. He kept going from one doctor to another doctor. His eyes started getting red and red and red. So nobody bothered actually to, stop the steroids and just take away anti-glaucoma medication. Keep it simple. So that was the moral of the story. Try to keep things simple.
Yeah, probably we shouldn't be straitjacketed into thinking that always the HLA-B medicine will cause a hypotenesis. Might be an exception to
So,
that.
if you see, so I've got so many cases now. I haven't seen like a major pressure difference. It's like usually like if it is 18 one eye, 16 other eye, 16 other eye, just a 2 or 3 millimeters mercury difference max actually.
Hmm.
Only one case I remember where the pressure in one eye was 20 and other eye was like 11 or 9, something like that actually to begin with. So it's not like a major hypotony is happening.
Yeah, okay. I think we should always keep an eye on this. I mean, it's a very interesting point which you had brought up, like pressure variations in HLA-B condition. Yeah, probably we should.
And I had presented a case when we had this LVPI classes. So
Mhm.
that was my first patient with HLA B27 positive, also Montu's positive. I'm not talking in regard with the glaucoma aspect, but in regard with HLA B27 uveitis and another infection also. That person had to be put on ATT, but somehow the physician didn't agree, and then I lost the patient on follow-up. So he
Hmm.
did have posterior segment involvement, but your case didn't have posterior segment involvement, right? Okay, sorry.
Yes, yes, ma'am. In fact, there was no inflammation in the eye. Mother, there was no uveitis as such. Mother, there was inflammation as such. Mother, like his eye was looking very dead, but there was no cells and flare. The vitreous was clear. The retina was fine.
Yeah. My patient also, he had hypopyon, shifting hypopyon. If you remember, I shared that case in 21
Hmm.
when the course started. But yes,
Yes.
with HLA B27 and higher IOP, everyone has a spinning head.
Hmm.
Sir,
So
one question. Uh,
please, please.
yeah. So, like, if you find a case like this with uveitis and high pressures, and there's a confusion in the diagnosis between HLA-B27 or a viral uveitis, considering that I've never seen a hypotenuse eye in HLA-B27, so sometimes this kind of a situation arises. So, how commonly would you want to err on the side of viral and start antivirals in such a case?
See, the first thing is the season. Mother, like I'm just going grossly by a general ophthalmologist, busy OPD practice. Honestly, the season, there's certain change. Whether it is viral, will come with change of weathers. One
Right,
thing.
sir.
Second thing, usually it will be granulomatous and not non-granulomatous, and then one eye. Sometimes the other eye may be involved. It's not always that it is bilateral. Then the grade of cells and flare, it may be all equivalent to HLA-B27. Like HLA-B27 can be even very severe. But in viral, there's usually an antecedent history of fever, like some sort of a pharyngitis or cold and cough. So that is there, and so that is for me. It is like it's associated with a seasonal change and granulomatous anterior uveitis, high intraocular pressure, and my I'll say max apart from herpes zoster, if it is just because that seasonal sort of a viral anterior uveitis, the iris is usually fine. There's nothing happening to
Right.
the iris, and the pupillary reactions are fine. Uh, there is even no corneal edema even at pressures of 38, 39. to 40. So I'll start them on Velcivir, and I usually put them on just fluoromethalone just to see how well my Velcivir is working, just to try to see if it is viral. So put them primarily on an antiviral agent actually.
Right, sir. And so the longest that your patient of viral anterior uveitis has lingered with this problem.
Three weeks, though I have
Mm.
continued medication for up to a month, so but 3 weeks, pressures usually settle down very fast. If the inflammation within a week, the pressures come down.
Right, sir. Because I have a patient, the patient was treated by another doctor for almost like 3 weeks, labeled as a viral anterior uveitis. The patient had records of high pressure in the range of 35, 40 something. And he was put on anti-glaucoma, he was put on steroids. The patient responded. As soon as we started stepping down the medication after 3 to 4 weeks, the pressures went up again, and then again there was inflammation. Now it's 2.5 months already.
Okay,
So
so
I put him on Acivir though. He has to come for follow-up yet. I even
see,
ordered an HLA B27 for this person.
ACV, for me, ACV is not working unless
Right,
I'm
sir.
800 milligram 5 times a day, which I'm really
Right, sir.
reluctant. Well, CV is easier on the patient. Just take one tablet twice a day or thrice a day. They're happier
Right,
actually.
sir. Okay.
Yeah. So
Right,
let's
sir.
move to the next case. So finally
All
found
right.
two left.
Can I say something?
Yeah, please go ahead.
What I gather from the last three cases is that these are the cases that don't really follow the book, and it's really commendable that now if I had seen someone with 50
Last
IOP, I
two.
would have jumped and started
Yeah.
mannitol or even Dimox, and it's I feel even though we don't have a straightforward diagnosis, somehow we have managed the case well, and we've got the IOP down, and your patients are doing well on the follow up.
Yeah. So, Madhab, like my idea of presenting these three cases, what I'm gathering from the discussion is we are mostly retina uvea people here actually, and through a magnifying glass. But for a general ophthalmologist, the idea I wanted to present across was like not all high intraocular pressures are ocular hypertensive. Don't put them on anti-glaucoma medication for their life. This was my idea actually. And just keep reviewing your diagnosis. The pressures come down. Take away your anti-glaucoma medications. These are young people. Don't let them, suffer the anti-glaucoma medication for their lifetime.
Something is with 31 in your presentation. This is the third patient who's 31 years old.
Oh, sorry. No, like it's just maybe okay.
Yeah.
Okay. Finally found true love. So this is again young chap. Pressures, high pressures, open angle gonioscopy, CCT slightly lower side. Diurnals, the pressure didn't go down, go below 30 millimeters of mercury, and the fundus looks all right, and the red-free images look all right. The some changes on OCT, visual fields are all right after the initial learning curve, and so diagnosis. I put him on three drugs. Pressures came
The visual
down, and
fields, can
did
you
a
just show
time-
them once?
sorry.
The visual fields, can you just show them once for our learning?
Yeah, yeah,
Yeah,
yeah, yeah.
those yellow spots, aren't they significant?
Not really significant. I have not put the entire visual field analysis. There was nothing in the pattern standard deviation plots, and so they are just a general reduction of sensitivity. And
Only if they
so
turn green and brown, you want to label them as
just see, I have if I have put the complete visual field, no, I would have taken a couple of more slides. So nothing on pattern standard deviation from the second and third visit. There was nothing there actually.
okay.
So these are just a sort of a gross representation of the visual field. Usually, the glaucoma specialists not like to even look at them, the gray scales. But yeah, for a general representation, they are pretty good. I do look at them all the time. So yeah, I made a diagnosis of ocular hypertension and put him on three drugs. Pressures came down, and did a trial of reduction of AGM, as actually I'm very infatuated on proving that everything that it is not glaucoma. the pressure went up. So continued with anti-glaucoma medication over 1 year. The visual field, everything remained stable. Again tried to put to reduce the anti-glaucoma medication. Pressures again went up. So yeah, the patient is now on 3 drugs and he's happy using them. He's content. So the patient, finally, this is a case of typically ocular hypertension. And yeah, the incidence can be as high as 42% in patients of ocular hypertension or development of glaucoma changes. So be careful there. So yeah, I think there were a couple of more slides here, or yeah, every. So this is the next set of cases where the suspicion of glaucoma developed because of the structural changes. So this is a slide of optic disc hemorrhage, which typically is splinter shaped on the rim margin, and it is rare in a normal population, these disc hemorrhages, and their presence called trans hemorrhages after Dr. Stephen Trans, and his seminal work established the link between optic disc hemorrhages and the progression of glaucomatous damage. So there's a strong suspicion of an active disease and glaucoma progression when you see a trans hemorrhage, and of course they can be present in other conditions too. So this is the patient I presented in the group earlier, and he had this nice little disc hemorrhage superiorly, and the yellow dots in the left eye there are hyalosis, and he was a hypertensive, and he stopped with antihypertensive medication. So this is how his testing looked like, everything normal. So sorry, I think I missed a slide here. Sorry, I'm jumping the slides. So yeah, it resolved actually with some collaterals. So with his controls of his blood pressure, the bleed went away, and there are some collaterals here. So testing is normal. Final diagnosis hypertensive retinal bleed. So should I go to the next case? Nothing here much.
Yeah, I can go ahead.
Yeah. So next case is a 65-year-old male. He has poor vision in the left eye, 660 there, pseudophagia both eyes, pressures are normal, CCT is okay. And so this is how his left eye disc is atrophic. There is not severe significant cupping, but it is atrophic, and inferonasally there is probably a resolving BRVO here. Nice little disc hemorrhage here, and I presented this in the group also, I think. So there's a suspicion of nerve fibrillary defect here and here, and on the red-free images, so this is more prominent, the nerve fibrillary defect in the right eye. So this is how his RNFL analysis looks like. And the GCL analysis, there is a universal thinning in the left eye. There's some change in the right eye as well. So he was not able to do the fields no matter how much I tried. And so my final diagnosis for this case was NAION, non-arthritic anti-ischemic optic neuropathy. And the change in the right eye could probably be an impending NAION, and could even be normal tension glaucoma, but he was not able to do the field. So I'm not sure there. Anyways, in all patients of NAION, though it is not universally recommended or proven, but I do put them on brinzolamide or a combination of brinzolamide or brimonidine actually. Sorry, brimonidine is, yes, I do put them on brimonidine to reduce the pressures and to improve the perfusion pressure of the disc, and for some sort of a neuroprotection. So I'll go to the next case.
Yeah.
Yeah, so this is finally infatuation or true love. So came to with me with poor vision, cataracts in both eyes, pressures are 13 and 13. Sorry, I did a diagonal up and open angle on gonioscopy, and this is how his fundus look like. So there is a disc hemorrhage here and here, and there's a NFL defect here, and the left eye very prominent NFL defects. Nice images here on red-free imaging, NFL defects. Right eye, even superiorly, there's an NFL defect. Inferiorly, it's sort of shadowed out, not very clearly visible. And this is his RNFL mapping, thinning in both eyes. So visual field mapping in both eyes, nasal defects. Left eye seem to be a central defect also. And so this is a central field. In central field in the left eye, there's the central field involvement, typically known to happen in normal tension glaucoma patients. So takeaway message from this slide is do central field in all your patients of glaucoma, all patients of glaucoma. And if there is involvement of the central field, need very aggressive management. So yeah, this is an interesting slide, the GCL analysis map of this patient. And so this is known as a temporal reference sign, this thing. So if you see this in your patient of glaucoma, it is probably glaucoma. So this is likely glaucoma, not other optic neuropathies. And Dr. Lee and Dr. Kim, they published a work on this. And this, if you see this sign, this is helpful in discriminating glaucoma from other optic neuropathies. So the diagnosis is normal tension glaucoma in this patient. So I've stressed more on metabolic control because with anti-glaucoma medication, it is not known that you cannot pressures really down in normal tension glaucoma patients because the pressure is already on the lower side. So the metabolic control is very important. You have to look at the weight, the diabetes, the hypertension, the serum lipids. You have to get the metabolic control in place and try to reduce the pressures also. So this is how the way to manage normal tension glaucoma. So interesting leads. So this is a very interesting case. So I've titled it as DNA does not match. So by DNA here, I mean the pressure. So the pressure, the intraocular pressure is the DNA of the glaucoma disease. So I've seen him 3 years back. 3 years back. So when I saw him 3 years back, he was already on anti-glaucoma medication for the last 2 years, and he had seen glaucoma specialists in Delhi and in nearby cities, and he was on 3 drugs in the left eye and on 1 drug in the right eye. And when I saw him 3 years back, his pressures were 12 in both eyes. The gonioscopy was open angles. The anterior segment were unremarkable. Pressure, vision was all right. And this is how his disc looked like. Right eye seems okay, though there's a hint of NFL defect here. And the right and the left eye, it seems definitely notched. Left eye superiorly notched and slightly pale disc also. And the red-free images, there is NFL defect in the right eye. And sorry. Sorry, I have to move my place. Just I'll continue with the stock. And in the left eye, there's a large NFL defect superiorly. And this is the RNFL analysis. Sorry, just give me a moment. Yeah, that's okay. And this is the GCL analysis, the left eye superior temporal defect. So the visual fields, now the interesting part was the visual fields are very stable. In the left eye, you can see even the graph going up, but this is just because it's got smarter at doing the visual fields and getting better results. And in the left eye, if you see, if you draw a line through them, you see the mean deviation has been normal, or you say the diffuse defects and the local defects. So almost a straight line. The scotomas haven't deepened. There hasn't been a spread of the scotomas. There has been a depression, in general depression of the field. So the visual fields have been very stable of the last 3 years that I've seen the patient. And very importantly, the pressures, they have always stayed around 12 millimeters or 30 millimeters of mercury. So in glaucoma, it is rare that you get such a very stable intraocular pressure. And here in the left eye, so this is the progression analysis of the left eye. You see a very straight line in the graph, so very stable fields. And now, after reviewing his visual field for close to 2 years and with good compliance, I decided to stop anti-glaucoma medication in the right eye and step down the anti-glaucoma medication in the left eye. But this year, I noticed here this collaterals actually. So these collaterals. So I missed them completely over the years, and so this is actually a case of superotemporal BRVO in the left eye, and this thinning of the rim superiorly. It is all because of the superior BRVO, which has resolved, and loss of blood supply here has caused the death of the ganglion cells and this thinning of the rim superiorly here, and some pallor here. So I've now further stopped down to the anti-glaucoma medication to single drug in the left eye, and there's none in the right eye. So this is effectively a sort of a, you can call a one-time episode. It's not a continuing case of glaucoma, and but I haven't stopped his medication completely because this disc is definitely now at risk. because it has suffered ischemic insult. So I just continued on one glaucoma anti-glaucoma medication. So that's the case. Should I proceed? So
We have time. Yeah.
yeah, so this is the next case where no one went. There's joy to find in the unknown. Let your spirit unwind, uncover wonders. Let your heart be content. Embrace the joy for looking where no one went. So very interesting case. We labeled this as passion becomes poison. 41-year-old male diagnosed as glaucoma elsewhere came to me for review of his glaucoma status, and visions are normal, and vision is normal. Sorry, pressures 16 millimeter mercury at the time of presentation. He was using PG analog in both eyes. He was on one drug, and gonioscopy, open angles, anterior segment unremarkable, CCT within normal limit. This is how his disc look like. There's a definite temporal pallor here in both eyes. The red-free images. So yeah, this is an interesting slide. And so the RNFL analysis shows a temporal thinning in both eyes. GCL IPL map shows universal thinning in both eyes. So macular area is the one which has taken the maximum beating here. There's thinning in both eyes, and the visual fields are remarkably clear. There's not even a hint of any sort of a damage. Supernormal fields here. So, in view of the temporal pallor of optic disc, both eyes, I put him through neuroimaging. It's normal. Put him through blood count, peripheral smears, B12 levels, homocysteine, and a couple of other tests. Everything was normal. So I probed further actually and found out that he's a photographer by profession, and he has spent the last couple of years in the high altitudes trying to film the snow leopard for National Geographic, and he has also been filming the solar eclipses. So my diagnosis in this case was sun-induced ganglion cell loss. So word on solar retinopathy here and their publications. So the moral of the story is embrace your skills, take control, don't let the machines dictate you. So I have taken him away from all anti-glaucoma medication. He is not a case of glaucoma, and I've discussed it with him, and he is regular with his follow-up, and visual fields have been very stable. And the last case for the day, just start with a couplet: images deceive, a tale they weave, truth lies beyond what they achieve. So this is a case of visual deception. And again, 38 years male, and he came to me for a second review yesterday after 6 months. And he came just for a routine checkup, heaviness in both eyes, and pressures 20 to 23 in both eyes, CCT normal. And I couldn't do a gonioscopy because the patient is very apprehensive, and he is a little bit unsound in mind. And so this is how his fundus look like. That this looks very suspicious. Some temporal pallor here. So the RNFL analysis all over the place. By now it looks like glaucoma to me. His last visit, I didn't put him through visual field because I doubted that he will be able to do the fields. But then the GCL analysis this time, there's this vertical homonymous defects on GCL analysis. This is very interesting. Happens mostly in optic tract lesions. So this now becomes neurological from glaucomatous. And this time I took him through the fields, and with some patients over 1 hour, he was able to do these fields. So there's a homonymous defect right side there. And so we have actually, me and Dr. Madrema, we have got this article published in the iNet magazine, Decoding Visual Pathway. And here we have put forth this, if in optic tract lesion, we get this sort of a pattern. And though in the left eye, though in one of the eyes, it is not exactly matching, but one eye we have got a similar pattern. So here, and the GCL IPL, so this is homonymous loss here. So we got almost a similar defect in our patient. And so this patient has history of childhood meningitis. So this is a neurological sequelae and not glaucoma. So in the woods where shadows silently sweep, I'll keep my mind open before I sleep. So that's the end of my presentation. Thank you if anyone is still there.
All there, sir.
All
We
are
all there.
Wonderful session, sir. Wonderful session.
Wonderful.
I really like the
and
last two
two
cases.
app titles, so nice. And you have put all those lines,
Hari poetry
Anybody has any questions, or shall I stop the recording?
Yeah, you stop the recording because we're going to upload it to the YouTube.